In this segment, we're going to treat a right-sided inflared innominate dysfunction. And in this dysfunction, you'll make the diagnosis similar to the way you would make a innominate rotation, anterior or posterior rotation dysfunction. So you could utilize the standing flexion, seated flexion test, and coordinate the findings of those two to determine that you had an iliosacral dysfunction, pelvis on sacrum, or you could use the patient prone, where they're passively lying prone, and you move the lower extremity, affecting the pelvis as it moves in relationship to the sacrum. And then, using the knowledge that you have a right-sided dysfunction, positive standing flexion test, for example, on the right, now we know we have the right sacroiliac joint involved, and determining whether this is different from an anterior or posterior rotation, where we would be looking for a cephalad and cephalad lateral, caudad medial, you'll just notice that the anterior suprailiac spine on the inflare side seems to be much closer to the umbilicus than on the non-dysfunctional side. So what we do is we take the right-sided dysfunction leg, bend it at the knee and hip. I take this patient's leg, draw it across. I'm going to anchor with my opposite hand the ASIS with the thenar eminence down on the ASIS, and the fingers drawn across the lateral aspect of the body, not to allow them to come across the midline. And then I slowly take my patient and pull that hip, or push that hip, into a little bit of external rotation, dragging the innominate with it into its restriction into the outflare direction. And now I ask my patient to gently push against my hand for about 3 to 5 seconds. So we go 1,001, 1,002, 1,003. Now relax. And then I get a little bit of a post-isometric relaxation effect that allows the innominate to come further laterally. Push out again into me. And relax. Let them relax, and then you just feel it slowly give. And you can repeat that contraction again. 1,001, 1,002, 1,003, and relax. And let it go. Find the new feather edge of the barrier. And you can do this 3 to 5 times. And when you're finished, you'll just bring the patient back to your neutral position where you originally made your diagnostic evaluations of these asymmetrical ASISs, etc., and reevaluate by the parameters you used that originally helped you make the diagnosis.